Let's talk a little bit about extracolonic findings. Again, I'm talking about some of the major areas of concern that Medicare had that I think that we've addressed sufficiently. And so there are multiple studies in the literature that have looked at the incidence of extracolonic findings in different patient cohorts, screening cohorts, as well as symptomatic patient cohorts. And you can see that the numbers are quite high in that you can see up to close to 70% of patients will have something outside of the colon. But I think the key column here is really the percentage of patients with significant extracolonic findings. And you can see that all the numbers drop, and on average what's quoted out there that you should remember is that about 10% of patients will have a significant extracolonic finding. Now, one of the main additional, I think, studies that have been performed to document this is that not all of these patients who you recommend additional workup will actually go on to have the imaging or whatever workup it is that you've recommended. And when you look at the long-term follow-up of these patients, it's actually half of that. So only about 5% of patients who have significant extracolonic findings will actually go on to have that workup. When you look at the additional cost per CTC exam, it's very reasonable. And on average, when you look at 4 of the studies that I have up there, ranges about $28 per CTC exam. This is just to show you some of the cases that we've had. This was a patient who had abdominal pain, very nonspecific, wasn't due to the gallstones. You can see a large renal cell carcinoma. This was a tough one, and you can see that this is a non-contour deforming renal cell carcinoma, and picked up on the CTC, and here it is post-contrast. What about this patient? Came in again with abdominal pain and clearly lymphoma. And I remember this case. This was a patient who was enrolled in one of our research studies and was to go to colonoscopy immediately after the CTC. And you can see that the colon was actually completely normal. The gastric wall is markedly and irregularly thick-walled. There's abundant perigastric adenopathy, and this was a patient who had gastric lymphoma. And so we went over to the GI suite and told him the patient actually needed an upper endoscopy and not a colonoscopy, which is what he had. This was a study by Hassan out of Wisconsin, who looked at the cost effectiveness of using CTC to screen not only for colorectal cancer, but for cancers outside of the colon, as well as for AAAs. And the findings were very supportive for CTC. It stated that CTC is a dominant screening strategy, more clinically effective and more cost effective over both colonoscopy and colonoscopy with one-time ultrasound. And there are studies that are coming out now looking at other areas that you can use CTC for, as I mentioned, for extracolonic malignancies and to look for AAAs, but also to evaluate for osteoporosis, looking for hepatic steatosis, and as well for visceral fat analysis.